Good evening, friends. Welcome to this Tuesday academic sessions from the Department of Critical Care Medicine and ECMO Center, Yashoda Group of Hospitals, Hyderabad. This has been almost close to 4 years where we tried our best to keep all the updated academics on the front and bring the sessions of interest. And in the recent past, it's a proud moment for us and all the ECMO physicians in India that one of our hospitals in India, Yashoda Group of Hospitals, has been awarded as one of the Platinum Center. We could only recognize the importance and the proud moment when we were a part of this also Congress in the recently concluded Washington Congress, where this the platinum centers has been very few even in the countries like United States of America. So as a country, as a society, as ECMO physicians, we felt privileged and proud for this opportunity. But in the same time, it's also a responsibility which comes along with us to keep the the responsibility on to us in providing this comprehensive care to a wider population in a cost-effective manner. In this proud moment, today morning, it was very disheartening and tragic moment that we came across. Can we have the slide of Dr. Robert Bartlett? So this is again a very sad day for us where we lost one of the father of modern days ECMO, Dr. Robert Bartlett, who has visionarily transformed critical care, offering this new extracorporeal therapy to many of these patients' life today. And with his pioneering work in this ECMO, many of us who could actually practice this therapy across the world and saved many lives. So in his memory, Dr. Robert Bartlett, we request all of you to spend few seconds of Mon so that we salute his presence. Okay, with this actually today in the memory of the father of ECMO, Dr. Robert Bartlett, in continuation of our web series, the webinar series of extracorporeal therapy, we brought something very what to say close to many of us in India. That is the extracorporeal therapy in toxins. See, we have been doing these webinars with some of the star worlds of um, globe, including the global leaders in different fields. But when we talk about toxins, either in the form of paraquat poisoning, aluminum phosphide, hydrogen sulfide, or many more toxins or a polypharmacy, the experience and even the data and the case reports are from this part of the world or this subcontinents. So we thought of concluding this session by bringing this ECMO, how it plays a role to tide over the toxin related crisis. So bring that, we have actually four of our very young, dynamic, seasoned ECMO physicians. We have Dr. Kaladhar, who has been a part of a very commonly encountered uh, antihypertensive polypharmacy, both calcium channel blockers and beta blockers causing severe myocardial suppression and unrecordable pressures leading to almost a death sentence, where he used these therapies and how he could help the patients out. I've been talking to my colleague and uh, previously a part of my team, Dr. Ravi Krishna, who is now heading in Kim's Hospital in Visakhapatnam, has also a vast experience from his DM time in Ludhiana, along with Dr. Vivek Gupta and team. So Dr. Ravi was talking to me when I met him in the last season in Vizag about his experience of bringing some of these industrial poisonings, which he could actually treat with a it was also experience for him when actually he got those antidotes. He initiated a bridging therapy with VA-ECMO and brought few of the patients. And Charan has been our frontliner with ECMO supporting many of these toxins. But we thought he will bring us some of those paraquat poisoning where he bridged. Even I think yesterday they had a patient who he bridged to a lung transplant, had some kind of instability. Otherwise, the transplant went well, and he will bring some light on that. I think we are also waiting for Dr. Vishal to be there, who will actually throw us some of those aluminum phosphide and industrial toxin. I think they've been running a 6 ECMO series in some of those industrial toxin exposure, which led to a catastrophic emergency in that part of the world. With this, I think we will have two of our experts who have been known for all of us, Dr. Oja and Dr. Vivek Gupta, who will join us during the sessions, who will give us an expert opinion. And to without delay, I request Dr. Kaladhar to begin his session, and all of us will probably try to keep ourselves to those 5 to 10 slides and 10 minutes to 12 minutes so that we can have a discussion at the end of it. Over to you, Dr. Kaladhar.
Okay, sir. Thank you very much, sir. So we pay our tribute to Dr. Bartlett, sir. Yeah, the pioneer. So I will share my slides. Can you see my slides, sir?
Yes.
Yes, sir.
Okay. So as Dr. Venkat sir said, I will be presenting on calcium and beta blocker poisoning case. So this is a patient who is around 26-year-old, mid-20s. She presented with alleged history of consumption of multiple unknown numbers of amlodipine and atenolol combination tablets. Some are sustained release. So she came in a drowsy state. Actually, initially they went to a local hospital where she was drowsy, and then later on they brought her here. So after coming to our center, the patient was drowsy. Of course, it is already around 4 hours after she took these tablets and started to develop severe hypotension. BP was almost unrecordable. So initially given some fluids and then started on vasopressors. Then hypotension was not at all improving. As we know, generally only one combination like a beta blocker or calcium channel blocker single itself can lead to catastrophic hypotension, but in combination they are more lethal. So, of course, because of this hemodynamic instability, ABG showing tissue hypoperfusion leading to metabolic acidosis, patient had to be taken onto, as we follow ABC, immediately intubated and started on ventilation with a bit of hyperventilation to compensate for metabolic acidosis. So then we did a gastric lavage, even though it is more than 4 or 5 hours, because most of the times these patients who consumed sustained release tablets, so there is extended absorption. So definitely activated charcoal along with gastric lavage can help in decreasing further absorption at least. So as everybody know, the regular medical management is other than regular supportive treatment, as I was talking about ABC. In these patients, high dose insulin therapy and calcium infusions are helpful. So high dose insulin therapy to the extent of 1 unit per kg. Suppose a 50 kg adult will be giving around 50 units of the stat dose, along with that 0.5 to 1 unit per kg, very high dose. These patients will be started on 25% dextrose, but most of the times what we observed is these patients being insulin resistant may not develop the hypoglycemic episodes that much. So that is generally the high dose insulin therapy will be acting in improving the insulin resistance, and carbohydrate resource acting as a substrate. Generally, the free fatty acids are the substrate for the myocardium, but when it is overwhelmed, carbohydrate may be the basic, acts as a basic, the substrate for the, as a fuel. So that's where actually we'll try to improve the insulin resistance. So despite the stiff vasopressor supports with triple vasopressor support, noradrenaline of 2.22 and adrenaline of 0.93 microgram per kg per minute, along with vasopressin up to the full extent dose, the mean after securing the artery line, the opening map is around 55. So with this, of course, the organ hypoperfusion started. The first one hit is the kidney. So there was a acute kidney injury and then worsening metabolic acidosis was happening. So 2D echo, as expected, it is global hypokinesia and LV dysfunction, severe LV dysfunction of less than 25% EF. So this is where it's been already into around 6 to 8 hours. We were thinking from starting onwards that the patient sinks probably go on to ECMO support, that is V ECMO support. So, because of refractory hypotension and in spite of maximal doses, she had to be initiated on peripheral VA ECMO, taking draining cannula as the femoral venous route and the return cannula as the femoral arterial route, along with the reperfusion cannula was put in. So, the ECMO flows were gradually increased to 2.8 liters and then between 2.5 to 4 liters, she was able to maintain good map around 65 millimeter mercury. Of course, being renal shutdown, CRRT was supported through ECMO machine itself. So then, of course, after VA ECMO, good support of the heart, the map was sustainably maintained because of which we could able to come down on vasopressors. The calcium infusion was being continued, targeting ionized calcium 2 times the upper limit. So she was started on low dose isoprenoline infusion to maintain, because the beta blocker effect is so much the bradycardia side, to maintain that we started isoprenoline infusion. So gradually vasopressin and adrenaline were tapered off and the patient was maintaining on minimal noradrenaline support. Subsequently, she could able to maintain and on day 4. So we could wean off the vasopressors completely later and decannulated on day 4 and later extubated on day 5. So she shifted to step down. So this is a very brief run of ECMO, because once the calcium channel blockers or beta blockers are the effect has gone, the heart automatically improves. So discharged on day 9. So generally, what happens when there is a severe calcium channel or beta blocker poisoning, there are generally, other than the beta blockade or calcium channel blockade, there are 3 properties generally what happens to poisoning, especially the membrane stabilizing action, lipophilicity. These are the things which determine the poisoning, and membrane stabilizing activity is the one which actually takes predominance in causing bad toxicity. So the drugs which are there, like antiarrhythmics, beta blockers, polycyclic antidepressants, SSRIs, dopamine norepinephrine reuptake inhibitors, and anti-epileptics, and then phenothiazines, opioids. These are all can be the potentially having membrane stabilizing activity causing severe cardiotoxicity. So generally, the supportive treatment initially is, of course, intravascular volume repletion with fluid loading, airway breathing circulation to be maintained with giving good atropine if the bradycardia is there, and vasopressors, initially noradrenaline followed by vasopressin, and third vasopressor as adrenaline, and sometimes phosphodiesterase inhibitors. It's a gray area. Other than that, antidotes most of the times for glucagon can be tried. Along with that, calcium channel blocker poisoning, we give calcium gluconate, dobutamine, high-dose insulin, as I was telling about that. These are the general measures that we have to take. So when we have to go for possibly considering ECMO support in these patients, life-threatening poisoning along with the features of heart rate consistently less than 50, QRS, prolonged QRS, and arrhythmias, and there is a severe myocardial dysfunction, as in our case, there is a global hypokinesia. So definitely these patients have to be referred early on to ECMO center. So they're all other supportive treatment and along with specific antidote. So the crux is, if there is a refractory cardiac arrest, refractory cardiogenic shock with life-threatening arrhythmias, and if there is a refractory vasoplegia, this is the time to go for extracorporeal love support. And early support is crucial, because once these develop very life-threatening, possibly, I think we should be ready before we try all this high-dose insulin and all. We should be ready for any catastrophe happening, and sometimes they may land up in ECPR kind of situation also. So I think this is the crux of management. I think, thank you. From my side, it's done, sir.
Yeah, thank you,
I will
Kaladhar,
stop.
for bringing the topic. Again, the bottom line there is, if I have a reversible cause, young, productive life, I just need to support the organ system for a couple of days or more. They're otherwise healthy, normal individuals, they will come back. So that's us. And This kind of polypharmacy antihypertensives are not uncommon nowadays. They've been considered as urban poisonings with family members with on antihypertensives, grandmother, father, parents. So it's a very easily available toxin which they can consume in it. Yes, medical management with volume vasopressors, calcium gluconate, and glucagon and dextrose and insulin therapy remain the first line of management. If somebody doesn't respond, extracorporeal therapy supporting for we have been experience of most of them doesn't need more than a 5 days to week time. By the time the 4 or 5 cycles of excretion either from the body metabolism or either by the renal replacement therapy takes out these toxins, and most of the time the organs, particularly cardiac, gets back.
Yes.
So moving towards the next industrial toxin, I request Dr. Amir. I am Ravi Krishna. Ravi, over to you for your cases presentation. I was very, what you say, very happy to actually listen from here and hear from you, and also been very glad to hear that you have been trying to procure all those antidotes from the industrial contacts, and you made a difference in somebody's life. Over to you, Dr.
Thank you, sir. Thank you once again for those kind words and for inviting me in this. I hope I can share my slides and are they audible? Are they visible, sir?
Yes, screen is screening. You can make it full screen. Please go ahead.
Yeah. So I would like to discuss two cases which I could manage at my center, provided I have the necessary time. So without further ado, I would like to discuss my first case. So this was a 33-year-old healthy male who was an industrial worker in a chemical pharmaceutical plant. So basically, this guy was working the night shift and they were supposed to wear PPEs and handle chemicals. So usually they mix chemicals in what is called as a scrubber. So two of the guys who were on the night shift went to handle these chemicals, and unfortunately the guy who was handling did not have a proper PP, so he got exposed to various chemicals there. So problem with industrial poisonings is very few companies acknowledge the type of chemicals they get exposed to and the probable byproducts they get exposed to because of the medical legal consequences, despite they being an FDA approved laboratory and FDA approved pharmaceutical company. So within few minutes of exposure, this patient collapsed, and another colleague of him went to pull him out. So the colleague who pulled him out collapsed and he died in a local hospital where he took him. So unfortunately, only this guy could be brought to our center. So when he arrived to our center, he was unresponsive with a GCS of around E1, V1, M2, sluggishly reacting pupils. So BP was around 100 by 60 millimeters of mercury, heart rate was around 140, and saturation was around 80. Auscultation revealed bilateral basal crepes. And once we intubated him because of his low GCS, he developed a GTCS. We treated him with a low dose of midazolam and shifted to ICU. By the time we started to shift to ICU, we started developing severe hypotension. We had to use almost around 4 vasopressors, and the vasopressor infusion score was more than 100. It was almost 110 by the time we reached the ICU. So we did an echo, and this was the echo which was in the early morning, 1 hour after arrival in our ICU. It was showing moderate to severe LV dysfunction with onset of pulmonary. So at this time, we didn't know what was the exact poison. After a lot of discussion with the company members, they told it could probably be hydrogen sulfide. So I had never treated a hydrogen sulfide poisoning, so I had to go through the literature. So when I went through the literature, it was found that it is what we commonly find in sewer gas, which is also called as a knockout gas. It has almost a mortality of around 80%. Very few survive it. And most commonly it affects heart and brain. So as I could see in my patient, the heart started getting affected. So I assume the hypotension was a combination of vasodilation and LV failure. ECG initially showed only sinus tachycardia. Troponin I was 345 nanogram per liter. And this was the main cardinal sign. He started developing hypothermia. So hydrogen sulfide is basically an inhibitor of cytochrome C oxidase. All your cellular oxidation pathways end with cytochrome C oxidase. This hydrogen sulfide inhibits the main pathway in the mitochondrial electron transport system. So the entire body's oxygen supply is no longer being met. So the carbon dioxide production and the thermal regulation is getting shut down, and the patient started developing severe hypothermia. And as expected, the patient's hemodynamics started deteriorating and developed episodes of VT. So as you know, if the patient develops VT and is hypothermic, no matter how many drugs you give, their effects will no longer be seen as expected in a patient who has normothermia. So because of his repeated episodes of VT, we had initiated a veno-arterial ECMO with a 21 French arterial in the right femoral and 25 French drainage canal in the right femoral vein with an 8 French distal sheath. So we had to go up to a flow of 3.5 liters. There was only mild LV distension. The pulse pressure was maintained. The aortic valve was also opening with every beat. So we did not need any venting. The mild distension, which was mainly at the LV apex, we managed with a low dose inotropes with a dose of around 3 mg per kg per minute. As expected, there was AK with oliguria. And one more thing which we noticed in this patient was the SaO2 in the ABG was around 99%, but the SvO2, which is usually around 65% in a normal male, is around 80%, meaning the patient's body is no longer using any oxygen as the electron transport system is inhibited. Over the next 24 hours, the SvO2 rose up to 90%, indicating that the entire body has been affected by hydrogen sulfide. So when I initially went through the literature, I found that there is only one antidote which can probably help, and it is recommended by the ATSDR. It is a branch of the CDC. It stands for Agency for Toxic Substance and Drug Registry. They are the registry for the entire world when it comes to toxic chemicals and how do you approach and how to treat them. So I knew sodium nitrate was the antidote, but you do not get sodium nitrate separately. So it is you get it as a part of cyanide kit. I had a cyanide kit, but unfortunately it expired by the when I had this patient. So I had to procure this antidote, and it is not available in my city. So when I had to get it by air, it took around 24 hours. So over this 24 hours, the patient was clinically stable but unresponsive. Neurologically, he was still the GCS of around E1 VTM2. As you can see, this was the arrival ABG showing a PO2 of 66 with a saturation of 87. At the same time, when I took a blood gas, it was showing an SaO2 of 83%. So I had to give the antidote. Once I gave the antidote, the SaO2 started dropping to 63%, indicating the O2 was being used. Now coming to antidote, how do I give an antidote on a patient who is on ECMO? Usually when we dose drugs on ECMO, we look at the PK/PD parameters. And we don't worry because most of the antidotes have a pretty wide therapeutic window. But sodium nitrate is one such drug which has a very narrow therapeutic window. You dose too high, patient develops severe methemoglobinemia, and you have an additional cause of cellular hypoxia. You dose too low, and you will not get the desired effect. And second, you do not have any additional dose of sodium nitrate to give. So I had to dose based on the PK/PD parameters. As you know, the PK/PD parameters are mainly dependent on the octanol coefficient. The octanol coefficient of sodium nitrate is not available. So we discussed with the German pharmaceutical company who were able to validate that the octanol coefficient was exactly minus 3.7, which usually correlates with other drugs which don't require any dose modification. So we gave a sodium nitrate and I dosed around 300 milligrams. Once the 300 milligrams of sodium nitrate was given, over a period of around 4 to 5 hours, the patient slowly started improving. He started improving neurologically with GCS improved to almost obeying commands. But as expected, immediately after the dose, the patient developed significant mild methemoglobin. I would rather say around 6%. So we again had to give him methylene blue to correct this. For the period of next 24 to 48 hours, we had to monitor LV function and SVO2, because SVO2 was the only marker by which we could identify whether the effect of hydrogen sulfide was still there or not. So we could gradually wean off, and we decannulated him on day 5. We still continued a low dose inotrope because he was still having mild LV dysfunction, which we stopped on day 7. We could discharge him with intact neurological function on day 11. So this was one case. So Venkat sir, can I?
Yeah, please go ahead.
Yeah. So hydrogen sulfide is the second most common cause of toxic gas induced ASA. The main problem is it acts on two main organ systems. One is the brain and second is the heart. In the brain, it directly shuts down the respiratory center. So patient develops apnea and becomes unconscious. And when he becomes unconscious at the site of exposure, he continues to have further intake of the gas, which will further precipitate other organ failure. So the second organ system which is affected is right heart and left heart. Predominantly, though it presents with LV failure, other organ systems like liver can get affected. Predominantly, it is the heart and the liver. So mechanism, like I said, it inhibits the cytochrome C oxidase, leading to anaerobic metabolism and lactic acidosis. And when the poisoning is severe, the patient also develops severe hypothermia. For the first time, I had to see my the thermal regulator running with a thermal output of around 200 watts just to maintain his core body temperature. If the core body temperature is low, even if you give your antidote, it no longer works. For every 1 degree Celsius, almost your metabolic activity decreases by around 10%. So I had to maintain euthermia alone, which was also possible only with an ECMO. So previously, few people have tried hyperbaric oxygen therapy, but again, as long as the effects of hydrogen sulfide are not reversed, it doesn't function more. And you have to usually we do hyperbaric therapy in sessions of around 90 or 120 minutes. To do a prolonged hyperbaric therapy, you would probably need services of a naval division, because only they have multi-chamber therapies which can run for more than 48 hours. The second thing is scavengers and antioxidants like methylene blue, or in the worst possible situation, only symptomatic therapy. So the main problems I faced with using veno arterial ECMOs, conventionally for all veno arterial ECMO, we match DaO2 to VO2. So we maintain a DaO2 VO2 ratio of more than 3 to 1 to prevent anaerobic metabolism. To calculate DaO2, we need SVO2. But any poison which affects our mitochondrial oxidation system, our SVO2 becomes unreliable. The two main poisons which we see world over which can affect the mitochondrial system are cyanide and second is hydrogen sulfide. So in this patient, though the SVO2 is high, we should not be tempted to reduce the flow because the patient is extremely dependent on ECMO flows. So until we give antidote, we never wean the ECMO flows. Second, like I said, the dosing. We do not have any literature which suggests what dose of sodium nitrate has to be given in patient on ECMO. Because too small a dose, it will lose its benefit. Too high a dose, it will worsen methemoglobin. So this is a second case. So this was another 38-year-old male who works in a pharmaceutical company, a different pharmaceutical company. He had exposure to isobutyl nitrate at his workplace, following which he became drowsy and he was taken to a local hospital where he became comatose and was referred to our center. On arrival, he was comatose with a GCS of around E1, V1, M1, sluggish reactive pupils with bradycardia. On arrival and immediately within 5 minutes of arrival, he developed a cardiac arrest. We gave CPR for around 30 minutes, following which we could resuscitate him. During this 30 minutes, there were 4 episodes of EF which required defibrillation. we could attain ROSC, and when we went through the literature, we found that it is an alkyl nitrate, so it causes methemoglobinemia. And as expected, when we looked at the ABG and the SpO2, there was a SaO2 and SpO2 gap, which suggested deshemoglobinemia. So we started him on a methylene blue at a dose of 2 milligram per kg, but the patient's hypertension continued to worsen, requiring increasing doses of vasopressors and inotropes. The echo was searched of LV dysfunction with a normal RV function. So conventionally with methemoglobinemia, we usually don't see LV failure. We initially thought it could be post-cardiac arrest, which was causing LV failure and due to myocardial stent, but the LV was still poor. So patient once we gave the antidote, the patient's sensorium improved. He started to occasionally obey commands, but was irritable. But again in the ICU, had a cardiac arrest due to polymorphic VT this time. We initiated ACLS, but the patient was fit into I even used cervical sympathetic chain blockade. But again, the patient continued to have recurrent VTs. So as I didn't have any further option, we initiated an ECPR with a 25 French venous cannula in the right femoral vein and a 19 French return in the left femoral artery with a 8 French limb perfusion cannula. Patient continued to have 5 more episodes of VF and 3 episodes of VT over the next 24 hours, even on ECMO. So we managed only with defibrillation, and I started a lignocaine infusion at around 3 ml per hour along with methylene blue. So this was the ABG at admission, which showed a lactate of around 15. Post CPR also it was showing still 15. And on admission to the ICU, it was a lactate of 8.4, which continued to worsen till we initiated ECMO. By the time we initiated ECMO, the lactates were around 8.9. So the patient's hemodynamics improved gradually, and there was no requirement for vasopressors on day 2. And since the patient was having VTs, which was the main cause of initiation, we waited for 48 hours of no arrhythmogenic activity. After 48 hours, the LVF also improved to around 40%, and we decannulated him on day 3, extubated on day 4, and discharged on day 5 with a full neurological status. Coming to the mechanism, it usually causes cellular hypoxia due to methemoglobinemia. But in this patient, because nitrate was the main cause, nitrate occasionally can cause a rebound vasospasm, specifically targeting the coronary arteries. So it can present with any form of ventricular arrhythmias, cardiogenic shock, and it also causes increased use of free radicals, which can further present coronary vasospasm. And rarely it can also specifically affect the macular arteries, causing maculopathy and loss of vision. Luckily, our patients did not have any vision loss when we also screened with oculoscopy. Thank you, sir.
Thank you, Ravi, for those 2 interesting cases. Maybe we will discuss in the later half with that. Do you feel that the all subsequent consequences of polymorphic VT, cardiac dysfunctions are the consequences of hypoxic cardiac arrest and leading to that, or the nitrate has any role to play as a toxin to do that, or you have this methemoglobinemia as a role to play?
So I actually, when I went through the literature, there were 1 or 2 cases where it was found that isobutyl nitrate causes refractory VFs. So actually isobutyl nitrate here, it is not a substance of abuse in India, but in the Western countries, people use it as a substance of abuse to get a bit of euphoria, sir. So they usually inhale it or drink it. So in those cases, they found that in 1 case, the patient had VT, but they could manage without requiring this.
We will take the other 2 cases, then probably we'll start discussion. We have 2 pioneers in extracorporeal therapy, Dr. Vivek and Dr. Pranay sir is with us. So we will take those questions with them. Charan, over to you. The seasoned ECMO clinician from Yashoda Group of Hospitals. Please bring us what is your series. I think in the last week you had a couple of transplants bridging from a paraquat. Over to you, Charan.
I thank you for the opportunity, sir. Is my presentation visible?
Yes, yes.
Okay. Before I start my presentation, I would like to pay my respects to the pioneer in ECMO, Dr. Robert H. Bartlett. It's very rare where a doctor is directly responsible for probably saving more than 100,000 patients around the world. That being said, in his honor, we'll be continuing with the presentation. So I'll be presenting about ECMO in paraquat poisoning. So we know that paraquat is an agricultural poison. So it is a chemical that is used mostly in agriculture. It's a rapidly acting herbicide and it's an effective herbicide. So probably that is the reason we are actually using that. It is very difficult to get this molecule out of the market because of its efficacy when we really speak to when we really discuss about its herbicidal properties in agriculture. So what does paraquat poisoning cause? Paraquat poisoning causes typically multi-organ dysfunctions. So it can cause various systemic reactions. It can cause pulmonary edema, liver injury, kidney injury, owing to the production of free oxygen radicals. So the most common complications are the rapidly progressive interstitial fibrosis, which can lead to respiratory failure and death. So even though it is actually mentioned in one of these papers that the mortality rate can go as high as 40 to 80%, in our experience, if the patient has consumed or if the patient has either accidentally or voluntarily consumed good amount of paraquat poisoning, the mortality rate almost reaches 100%. And almost in all these patients, the major cause of mortality in patients who have consumed paraquat tends to be respiratory failure. So the one major important thing which typically separates this poison from the other poisons what we were discussing is that there is no specific antidote. We cannot decrease the pulmonary rapidly progressive pulmonary interstitial fibrosis which occurs secondary to paraquat poisoning. So there is no bridge to antidote in this concept when we are talking about a paraquat poison. So as I was discussing, there is free radical generation, then there is cell membrane damage. It involves kidneys, which can cause damage to the proximal tubules, and the patient will be requiring hemodialysis very early on in the course. It will cause liver injury. It causes progressive pulmonary fibrosis, and the lesser known involvement, it can cause some cytopenias, or in some cases, it can even cause seizures. So the thing is, among these involvements, what we typically see is that patients who have kidney injury, almost all the patients present with kidney injury, liver injury. So in majority of these patients, these are reversible. So they are temporary, and over a period of time, the kidney is known to recover. Their creatinine starts to come down, their urine output starts to improve, and their patient's metabolic acidosis tends to get better. However, the lung, when it starts to worsen, it almost goes and it worsens in an exponential scale. So the various effect on other organs include even the oral as well as the esophageal ulcerations with secondary bleeds, which can actually happen in these patients because of the caustic nature of the poison. And the management from when it really comes to managing a paraquat poison is mostly supportive in the sense that if the patient develops kidney injury, we dialyze the patients and the patient oxygen therapy as going to as high as mechanical ventilation. So what are the various problems which we have seen when we have a patient who has consumed paraquat? So there is rapid progression, there is multi-organ dysfunction. The most important thing being that there is no antidote and there is symptomatic treatment and immunosuppression. However, when it really comes to the initiation of ECMO in these patients, so when it really comes to the initiation of ECMO in these patients, we probably the initial reservation of when to initiate ECMO in patients of paraquat poisoning is limited to the fact that we have been because there is no available antidote. We don't see patient who presents to us with the paraquat-induced respiratory failure as a patient who has the potential to come back, who has the potential to get better because of the progressive respiratory failure and non-availability of the antidote. So classically, as per our ECMO teachings, we were taught that in these patients, it is imperative that we have to also look at the reversible nature of the disease before we initiate an ECMO. Otherwise, it would be a bridge to an organ transplant. However, organ transplants have been tried in other countries, but they were not with very encouraging results. And they were actually trying to understand what is the best timeline because of its rapid and high volume of distribution and distribution to muscle as well as fat. there is slow diffusion of this poison back into the bloodstream, which have been reported in cases where even the graft, which was patients who even underwent a lung transplant, even their graft starts to get fibrosed, and the postmortem analysis of these organs is known to be similar to that seen in paraquat poisoning patients. So it was a rather established fact, albeit with an anecdotal evidence with the case series and case reports, that too early a lung transplantation can actually cause reaccumulation of paraquat in the tissues, thus leading to rebound respiratory failure. So we will be in a fix on to understand the timing of ECMO, timing of transplant. So this is actually a case. This is a 26-year-old male with the accidental consumption of paraquat at his home. He was brought to the hospital, and in the initial management of the paraquat poisoning still remains the same though. So he was done charcoal hemoperfusion. He was started on hemodialytic supports. The central line and the arterial lines were taken. His hemodynamics was stabilized. Airway breathing circulation was stabilized. This patient also has significant amount of airway oral ulcerations, which were actually being managed conservatively. However, because of the quantity of the paraquat, by day 8 or day 7 of hospital admission, he started to develop tachypnea and shows signs of respiratory failure. However, by day 10, we can actually say that the patient was requiring oxygen, and it was completely downhill from there. So initially, he required at the time of the hospital admission itself. So he was started on, he has AKI, he had hepatopathy. So he has developed conjugated hyperbilirubinemia, and he also has developed acute kidney injury with oliguria, for which he was started on hemodialytic supports. So he was on continuous hemodialytic supports, and then he was initiated on oxygen. And after we initiated him on oxygen, it was all downhill from there. So there was a rapid worsening in the lungs. His oxygen requirement went up in a span of 4 to 5 days, where he was subsequently intubated, mechanically ventilated, but nothing was working. So in order to try, so because after counseling the family members that we can try a lung transplantation, which is not a very common indication for paraquat lung poisoning, which was not hardly was tried anywhere. The family was convinced that they can try a lung transplant in these patients, and after getting an informed consent from them, that saying that only lung transplant is the end game here, we were able to initiate ECMO in these patients. So we have initiated ECMO by the right femoral root and the right jugular root with a 25 French right femoral venous cannula, as well as a 19 French right internal jugular cannula. So after initiation of an ECMO, like the next day, we were able to get a CT scan of the lung to see where we are at. So we can actually see in the subsequent CT scan on the 15th day of hospital admission, where the lung is completely consolidated and you can hardly see anything except for an air bronchogram. And there is this ECMO cannula which is actually being shown here. So he was subsequently initiated on ECMO. So similar kind of patients was on a 15-year-old male who has consumed greater than 100 ml of paraquat poisonings, and he presented to the hospital in a similar state. So this is actually a case series of 2 patients what I'm trying to present here. So the entire pre-ECMO patient characteristics remained fairly the same. So his preoperative liver function was deranged, preoperative renal function is deranged in both of them, and ingestion to ECMO is 15 days in patient 1, whereas 24 days in patient 2. So based on the available literature research, whatever we were able to find, the next thing is that now that we have initiated these patients on ECMO, we still have time to understand till at what time should we actually do a lung transplant for these patients. So the timing of the lung transplant was a crucial factor for which we were reviewing the literature, and this is where we came across this paper of anecdotal evidence from the case reports, saying that the postmortem reports of the lung in a post-transplant patient for a paraquat poison shows similar paraquat-induced changes. So majority of these patients were actually done within 4 weeks. So we have actually did a cutoff where one particular paper has actually showed some promise that after 28 days, the amount of paraquat that is present in the body is completely metabolized, or it's excreted, giving us a safe opportunity to do a lung transplant, probably hoping a good graft survival in these patients. So we were waiting for about 4 weeks after the ingestion of paraquat to actively register them for a lung transplant. So then the first patient was on ECMO for about 20 days, and the second patient was on ECMO for 6 days. So both of them underwent a bilateral lung transplant, and we have done urine diethynate test before, obviously we'll be doing that when the patient presents to the hospital, and then at the time of transplant, that is after 4 weeks, we have repeated this urine diethionate test twice, which were 24 hours apart, and both of them are negative in both these patients. So with reasonably good confidence that we went ahead and did lung transplant for these patients. We were actually initially trying to understand the quantitative paraquat levels in the blood, but unfortunately for us, those kind of tests are not available in India for us. So we had to rely on the urine diethionate test, and a negative urine diethionate test was essentially considered as a negative in paraquat, and then we went ahead and did lung transplant for both of these patients. So we can actually see that there is by day 15, by day 30, the bilirubins, etc., have improved. Even as GOT, SGPTs have improved. So what are the pre-transplant goals here? So the pre-transplant goals include early ECMO and preventing infection. Early ECMO in the sense that probably we were initiating ECMO almost immediately after intubating these patients, because we cannot have we don't have the luxury to wait till he again develops a PF ratios of very poor and then instituting on ECMO, because ECMO in these patients has actually helped with pulmonary rehabilitation, in the sense that it helped with improving overall physiotherapy, improving the muscle power, and able to maintain some degree of muscle tone, so that the post-transplant outcomes are better. So the next thing is that we were doing serial urine paraquat levels. Of course, blood paraquat levels were not available. Quantitative blood paraquat levels were not available. And obviously preventing organ dysfunction, most commonly which can occur secondary to sepsis. So by the end of day 20, day 25, we have actually seen that even though they're present with multi-organ dysfunction, majority of these patients, like we have a case series of around 6 to 7 paraquat lung transplants till now. So these patients, majority of these patients have developed, completely boiled down to a single organ dysfunction, that is pulmonary dysfunction. So serial bronchoscopies were actually done to do bronchial dilating, so as to prevent a source of infection or prevent source of sepsis from lung in these patients. So we were able to do the regular physiotherapy on awake ECMO. So whatever that is possible, we were able to trying to maintain this patient awake. And then we were able to do some passive as well as some active exercises on ECMO support. The major problem when it really came to doing active physiotherapy, out of bed physiotherapy for these patients, is that they have a very completely fibrous lung. Almost 100% of the lung is definitely involved, and essentially all the blood is shunted from the lung. So, and both of these are young patients, so they have a very good amount of native cardiac output. So I was actually able to run around 4 liters in this particular patient, as you can see. And any minimal exertion is going to increase in the cardiac output, and the patients were decelerating to quite precipitous levels, almost less than 60 to 70% at points. So the amount of physiotherapy we can attempt in these patients was also limited because of the nature where lung is absolutely not contributing to oxygenation at any point during their course on ECMO. So this is one of the very uncommon indications of lung transplant where paraquat induced lung fibrosis. So this is actually, you can see the left side on the day of transplant, we have a donor, we have a recipient X-ray which shows complete whiteout. And this is the X-ray of the donor which was matched. So it was a reasonably good height match, and it was an immunological, immunologically there is a good, there is no cross reactivity between these two patients, and we were able to confidently take this donor for these patients. As you can see, the actually donor explant was showing a very good pink lungs, healthy lungs. So what we can see is that with the pre-transplant X-ray, when I compare it to the post-transplant X-ray, so this patient has the immediate post-operative course was that we were able to decannulate ECMO by day 2. He was already tracheostomized by then. So after we have decannulated this patient, we were able to make him do a good amount of physiotherapy. So with physiotherapy, there were no significant post-operative infection course. We were able to maintain a very strict aseptic precautions when it comes to infection prevention and control. So this patient was able to get discharged by day 18 after transplant. So he was there almost for about 1 month before the transplant. He underwent a transplant and he was discharged home by day 18. So he was actually tracheostomized. So after getting a reasonable amount of physiotherapy, he was subsequently weaned off ventilator to a portable BiPAP, and from portable BiPAP, after all the drains and lines were out, we discharged him to a rehab center where he stayed for about a week. So, and then with good muscle power as well as with good cough reflex, we were subsequently able to decannulate him off tracheostomy also. So this is the patient for his 1 year post follow-up. So he was able to do very good amount of physiotherapy. He was able to actually show good amount of muscle power and exercise capacity. Even his post-operative pulmonary function tests were being monitored, and he is shown to be having very good amount of FEV1 and FEC values. So this patient actually for about the next birthday he went to Tirupati by foot. So he was able to climb all those stairs by foot, and which can actually tells us the testament that if adequately managed, these patients do have a hope, and they can lead a completely normal life.
Yeah, thank you, Charan. Many of us had a surprise post-transplant rehabilitation of these patients. Contrary to what we see with this chronic ILD with malnourishment debilitated, these patients are relatively young. Their other organs and muscle mass are relatively quickly preserved back, and their restoration of normalcy of the life has been, whatever I could observe, are very quick. The moment they get a lung, they jump into a normalcy in such a quick time, which is sometimes very surprising to many of us. Do you have Dr. Vishal Sardhar to present the last case? Charan?
Sir, it's not lifting the phone, sir. I
Okay.
think it's busy.
So we have Dr. Vivek Kumar Gupta, sir. Sir, we welcome you. Can you just switch on your camera, sir? Can you?
Yes, sure.
Sir, happy Diwali. Sorry to
Yes.
actually try to bring you to actually enlighten us with your knowledge on the occasion of Diwali, also to save more lives.
Thank you very much for the invite, and wish you the same. Happy Diwali to all of you. And really encouraging that there are so many people in the group who are listening and are part of this discussion on the day of Diwali. That's great. So we can continue.
Yeah. Charan, can you just stop sharing?
Yes, sir. I'm trying to stop
And
sharing.
we have Dr. Pranay Ojha, sir, who have been a alternative name to extracorporeal therapy, and we can consider him as father of ECMO in India. Dr. Pranay Ojha, sir, we welcome you. Can you just switch on your camera, sir?
Sir is traveling, so he was saying that it's
Okay,
difficult for him to switch on the camera.
Okay. Sir, back to you, Dr. Vivek Gupta, sir. If we talk about toxicology and extracorporeal support, we had none other name other than you to actually give us a overview of guidance. So three of our panelists, the speakers, Dr. Ravi, Dr. Kaladhar, and Dr. Charan spoke on the spectrum of toxins. Dr. Kaladhar spoke more on modern toxins of antihypertensives, polypharmacy with calcium channel and beta blockers, needing a cardiovascular collapse and VA ECMO. Followed by Ravi, Dr. Ravi presented two industrial exposure toxins, hydrogen sulfide, another one with nitrate, and having a very severe methemoglobinia, and also a refractory arrhythmias and LV dysfunction needing a VA ECMO. And Dr. Charan, I think, presented the last component which we are aware of, a paraquat. So we just wanted to hear from you. If I look at, we have been doing the webinars for the last couple of months of this 4-year series of online academic sessions from Yashoda Group of Hospital. In this, when we spoke about the respiratory failure related to ECMOs or a different specialized ECMOs or awake ECMOs, we try to bring some of those so-called Western country experts to bring line onto it. But when we spoke about toxin-induced crisis needing ECMO, I think you have been in the front line for many years in this area. What do you think? Do you think that India should be working seriously to collaborate this information? Because I can't see, whenever I actually search for extracorporeal therapy and toxins, most of an Indian case series, case reports come in the front line. We don't see much of the literatures from the Western world. What is your take on that from your beginning? Should we actually gather all this information?
Very rightly said. What you are saying, because probably we are getting much more exposure. If you look at the Western data, Most of the data is related with the beta blockers, calcium channel blockers, or some other medications. Because most of these toxins are medicine, and as per the American Poison Control Center report, latest report, or in fact, if you look at the report for last 5 years, it's the first thing is the medications which is leading to intoxication. And unfortunately, even use of ECMO there is not very good in the intoxication. Probably the reason which I could make out that there are only specialized centers, probably these patients do not reach actually to these centers. Because when I looked at their data, it was almost every year 12 to 1300 patients are having cardiac arrest with a very poor outcome with these. And only 4% patients are actually receiving ECMO. Only 4%. That's very less number if I talk about US. So probably, as you rightly said, that we can be a leader in that we can collate our data, we can publish our data because again, whatever Western literature you look at, it is variety of means if a case series has 20 poisons, 20 cases, so it will have five different type of poison or six. So they don't have much of the data. So probably we can collate the data and we can publish the data. We can have a registry actually, Venkat, you have given a very good idea that we can have a national registry through ESOI and we can always publish this data and we can batch to the international level with that.
Yeah, so taking your guidance and Pranay's guidance, I think it's the right time. Dr. Ravi and Sricharan can take the lead. We all can help and you can guide, both of you. Pranay sir, can you actually give any light onto it? Gathering data from India, and we should be the frontline lead for this, so on toxicology at least.
Yeah, in fact, we have started a registry, and almost I have 100+ cases of poisonings have been registered with us out of say around 700 case registry from Indian data, which we started last year. We have 100+ cases of poisoning itself. Uh, Obviously, without saying it goes to that 80% of the cases are the element of postpartum poisoning. Okay. So I think that's a good start. Only thing is that we need to gather more people contribution from everywhere. Because see, ECMO got popularized in India because of two things. One is was H1N1 COVID, and the second is self-force poisoning. Because if you see now, even in the tertiary care or even the tier 3 cities like Junagadh and that, also there are ECMO centers which are exclusively doing only for self-force poisoning, and they probably will not venture much into ARDS and that. So I think just we need to work it out so that we can have a more registry. Vivek has already started making a paper on systemic review, and after that we are going to make a guidelines. So me, Vivek, Ram are in the team, and some even the Ravi is part of that team who is making a systemic review, and probably that should come out in first part of 2026, and subsequently followed by a guidelines on toxicology with ECMO.
Fantastic, sir. I think then the work has already started. We all need to join hands for that.
Yeah.
Really,
While I
really.
request Charan to put his paraquat cases also, because paraquat is again seen mainly in India,
Yes.
and there are very few literatures. I think Madan has done 2 cases of paraquat poisoning with a transplant, and he has a successful transplant, and the patient is still alive after 1 year of transplant.
Yes.
So the world has no clue of when to transplant. So probably we might come out with that idea of when to transplant this patient and when to wait.
Yes, sir.
And we have enough number of paraquat poisoning.
Yes, sir.
Yeah, coming back to one at a time, sir. We were talking about this support for a bridge to recovery. In most of those with cardiac toxicity, needing a VA ECMO, cardiorespiratory toxicity, VA ECMO, respiratory toxicity, VV ECMO. So if we look at these presentations, with some of them were cardiac toxicity, some of them were both toxicity. So aluminum phosphide comes again, one of the series which we wanted Dr. Vishal to present. What is your take on those exposures, Dr. Vivek? Aluminum phosphide causing a severe cardiac toxicity and needing this extracorporeal supports for a week or so.
Yeah. So besides aluminum phosphide, we have done quite a few cases of heroin intoxication, which also causes is a cardiotoxic, potent cardiotoxic drug. Some of unknown poisons, probably they have taken some mixture of these recreational drugs, some of the amlodipine and other poisoning, and in fact, we have 3 or 4 inhalational toxins where they developed ARDS. So my suggestions and recommendations will always be that do not look at actually the toxin, because that will give you just an idea that do you expect any recovery or do you have an antidote. The presenting condition of the patient should guide you for the use of it. So that should be the first thing, because even if you have an antidote, but it's still if your patient has, because being a tertiary care center, patient might be coming to the hospital a bit late. So if he's collapsing, he's there throwing arrhythmias, or there is a severe cardiogenic shock, you might not get a time to utilize these antidotes or other therapies. So it's better to put them on ECMO if they are fitting in the criteria of ECMO initiation, because early the ECMO, better the results.
Agreed.
Once there are multi-organ failure has set in, then the chances of outcome, because that becomes then a problem, that kidney is not recovering, lungs are causing the problem, and gradually patient develops sepsis. So that we can always curtail. Those points, those issues we can always curtail. So look for the ECMO criteria. If the patient is fitting, irrespective of the poison, you can support them and you have a time to think. Yes, it is sometime it may not be like if we say paraquat. So obviously, if we know that there is no chance of recovery of the lung, is it's not a bridge to recovery. So those things, if you have a known poison, then definitely you should take in consideration. But suppose the patient is presenting like I'm talking about the 2, 3 poisons. Patient had a cardiovascular collapse, no clear-cut history, but vague history was there that it is intoxication. We put them on fourth day, fifth day on ECMO, VA ECMO, and they started recovering. They started showing improvement. So that has given us, and 2 patients who had exposure to these thinner material, what they use for the pain, and they had the severe ideas not responding. They were fitting in the criteria of ECMO. We went for ECMO in those 2 patients also, and they very nicely by day 10th, 11th, they started recovering.
Yeah.
So I think this we need to understand. Looking at the poison and other characteristics of a poison, criteria for ECMO probably should be much more reinforced for the use of.
Yeah. Thank you, sir. I think you put out that in a crux way key. Even though there are antidotes, if the patient is crashing and you need a space and time to the organs to recover back with those antidotes, so you need to bridge them to sustain the life for that period also. Oja sir, this became a very tricky in India. You have an antidote, you have a patient with a lot of what you say challenges in Indian context of availability, finance, many other things comes. What do you think the role of the ECMOs in India now and in future? Oja sir, are you there? Think this got disconnected. Sir, Vivek sir, how do you place to whether we can actually go with the conventional regular standard ECMO for a longer support, or we can start with the cardiopulmonary machines and then bridging them to this? Have you any experience in this kind of things, sir?
We had used the cardiopulmonary bypass machine, roller pumps also, because at one point of time we had 3 ECMOs running and a 4th patient came. So we had to start. And we were fortunate enough that that patient also survived, because we understand roller pump only issue is you have a risk of ruptures or those things. So we could take care of those things. So we could manage it. Being a established cardiac center, so we have a good experience of our perfusionists also, they have a good experience. So that can always be used. And for cost of the ECMO, I'll say that besides other measures of the reducing cost, like looking for a cheaper cannulas, looking for a shorter circuits, which probably is not in our hand, we can always talk to the industry and we can get it done. But cutting down the cost, like we still do not have Indian guidelines that how frequently we should go for ABGs, how frequently what test to be done. On every forum we talk anti-10A. Why to do anti-10A? I'm not against these tests, but only issue is when your parameters, other parameters are doing fine, look for the cheapest possible option to reduce the cost. Probably that is one big reason that we could do more than 250 cases of ECMO so far, because we were the cheapest probably in the country, except Dr. Pranay, because they have their own hospital, so they can go up to any extent. Being a corporate hospital, is still we are still very cheap in the country. That we hardly charge uh, from these patients. So probably this kind of motivations and communication with the administration, that will help us. That hospital looks their benefit two ways. One is the money, and second the name. So we can always project them with the ECMO. If your success, your patient is surviving, it will give you a big name, and probably you will have a more number of these. So those area also, I think, as a ECMO specialist, we should start touching with our administration.
So what are the poisons you enlist top to bottom in your center in India? What are the common poisons where you have initiated ECMO?
Okay. So aluminum phosphide on top, zinc phosphide number two, then calcium channel blocker. Because zinc phosphide, they are not the routine poison where there is they causes the myocardial toxicity. Routinely, they cause hepatic and renal failure, but when their dose is very high and certain, probably they have some mixture, so then they causes the myocardial toxicity also. And they really present with the three organ failure along with the ARDS, so four organ failure. Then third is the calcium channel blocker, then heroin, then other mixture drugs, then there's amlodipine and beta blockers. So these are the common poisons which we have come across so far. Besides, for VV ECMO, two cases of these painkillers. Probably they had the exposure and they had the severe ARDS after that.
Dr. Ravi, you have been speaking about hydrogen sulfide and some of these industrial poisons. We recently come across in the news, even in the city of Vadodara, we had a industrial exposure. There is a uh, uh, huge population got affected, and some of them went to a critical state in the ICU. So, how frequently you come across? You had one or two cases, but what are the common toxins or exposures you come across?
So most of them are basically alkyl nitrates, which cause methemoglobinia. Rarely we see these cardiotoxins. Actually, in December last year, we had a large phosgene leaks. So there were roughly around 48 patients were symptomatic. I received two patients, but at that time I didn't know whether the patient was going to survive or not. So I couldn't initiate. For the other patient, he actually rapidly recovered. It causes a non-cardiogenic pulmonary edema due to diffuse asymmetrical pulmonary vasoconstriction. Luckily, all of them survive. So it is actually pretty common in, I think it should not be common, but I feel it is pretty common in tier 2 cities where the regulations are a bit lax when it comes to pharmaceutical companies.
Okay. Dr. Vivek, any light on the recent, I think that was in hydrogen fluoride exposure, again needing a cardiac toxicity and VA ECMO in some of those cases. I think we could actually save few, we could not save few. Dr. Vishal could have been a right guy to show light. Any light on that?
Yeah, that's true. This is what I'm seeing, and why this is why I said that any poison where we suppose a patient, young patient is coming to me and with no previous history of cardiac ailment, and I'm finding that he's having a severe myocardial dysfunction, and there is a history that there is some exposure to any toxin, maybe known or unknown, because so many times it happens that you don't come to know.
Don't know.
So if there is a, and you are seeing that the situation is an acute cardiogenic shock, where you expect that no other therapy is going to help you in those situations. Lactates are rising, severe LV dysfunction is there, metabolic acidosis is worsening, patient is in the low cardiac output state. Then possibly that's the right time to think of. This is why I said that irrespective of the poison, if you are finding a situation acutely, then possibly that can be a candidate for ECMO to manage immediately.
Okay. So I think it's not about a known poisons. The toxin indications are getting wider and wider in India. If you see, we started with aluminum phosphide, we are widening it for different indications. I think you made a very right statement saying it is not about known toxins only, unknown toxins where you have a reversibility till on card. Probably those are the indications for this kind of extracorporeal temporary supports to save these more lives. I think, thank you, sir. Can you hear us, sir? Dr. Vivek, sir? Unmute yourself, sir.
Uh,
Can you hear us?
yeah, what's the question?
Yeah. No, sir, I got that point, a very, very valid and a very bottom line point. The horizon of toxin indication for ECMO is getting wider and wider day by day.
Yeah. Yes, true.
As you said, from a known poisons to we are slowly moving towards many other cardiotoxic poisons, lethal poisons, which has a reversibility. It is just a matter of time. You support the organ systems for that period of time till that antidote works or the patients self recover from those toxins and which go out of the body. I think, as you said, ki whether it is a known or unknown poisoning, if there is an indication that this patient may have a toxin-induced myocardial depression or dysfunction, support the patient, find out what he took, try to give antidote, give him a time to bridge to recovery, and find what is happening. I think that's what is the bottom line you try to carry to all of us, and that's
Yeah,
it.
that's perfectly right. You have put it in the absolutely right words. Because uh, the issue is, whatever the poison is, at least if it is a non-recoverable situation, now imagine any ICU patient who is coming to you. You are putting them on support with an intent that you may address those issues. And this is what exactly comes for the ECMO as well. The only issue with the ECMO is a pretty costly therapy and it is not available everywhere. That is the only difference. Otherwise, it is a supportive therapy and it's a life-saving modality. So you put the patient on ECMO, and that will give you the time either for recovery or for use of any other extracorporeal therapy like a dialysis, CRRT, if it's a dialysable toxin, or for correcting of the metabolic issues, or you can use the antidote. The only fourth thing you left with the transplant. So just imagine at least 80 or 90% patient can be addressed this way. Only 10% patient probably may land up with a non-recoverable situation. So offering ECMO in these situations can really be because these patients are usually young, those who get acute intoxication. They don't have a comorbidities. Their other organ functions are pretty good. So there is a fair chance of recovery. And as Dr. Oja said rightly, that in India, the popularity of ECMO is for two reasons only, H1N1 and intoxication.
Thank you. So thank you, Dr. Vivek sir, for joining us on the occasion of Diwali also and enlightening us with your knowledge and wisdom. And I thank all our three speakers, Dr. Kaladhar and Dr. Sricharan and Dr. Ravi for bringing those three interesting cases on the occasion of just Diwali. We wish you a very happy and prosperous Diwali in the memory of Dr. Robert Bartlett. We all actually keep this good work in his memory and keep remembering his all contribution to us. I thank all of the participants who joined us on this evening. Thank you very much. I conclude the session. Thank you.
Thank you very much.
Thank you.
Thank you very much.
Thanks.